Those of you who don't know Allan, he has been practicing neurology for over 50 years, he told me this morning. And a lot of that was at Kaiser in Santa Rosa here. He also has a position at UC San Francisco where he's done a lot of research, both in stroke, in Alzheimer's, and in migraine. Now, that for me as a colleague, former colleague of Allan's, I really appreciated this combination that he has in his training, because he combines the intellectual pursuit, the intellectual curiosity, with the practical advice. So whenever I asked Allan a question about difficult patient, I knew I was getting first line medicine, but also with the practical approach. So I'm hoping that that will be part of his talk tonight, is that same approach of curiosity and pragmatism. So Allan, it's all yours.
Thank you, Tom. I guess everyone can hear me. I can hear myself, so it's got to be good. On it. A pleasure to be back. As many of you know, I've been out here a number of times with the lifelong learning program. We talked about the amazing brain. We had a 12-hour class all about the amazing brain. So with this audience, I expect really good questions. Okay, I really mean it. You folks have been wonderful at questions. So I'm going to go through stuff. I'll try to get background. I'll try to give you what's current, what's in the news this last month about research in memory. We were talking earlier about some other things about memory and how come we haven't cured it yet? And the answer is, well, I've cured it in rats, but it doesn't translate really well to humans. So starting line is, how does it work? It's really relatively simple if you think about it. It's registration, which we call coding, consolidation, and retrieval. Kind of like your computer. It's input, store it, bring it back. Now, most important part of memory is paying attention. And we forget, bad term, to do that. In other words, if you have a conversation and you don't really care about it, and someone asks you about it the next day and you don't remember, and the answer is, I didn't pay attention, I didn't care. Other things that are real important when I look at people who have a memory issues, I look at the medications. People get more and more medications as they get older and older. And sometimes they take too many. And the reality is, as physicians, what we don't do is we don't de-prescribe. You get this drug and they say you'll need it the rest of your life, but the reality is you don't. And so half the time I see people who are on way too many medicines start cutting back and get smarter. Crazy. Sleep, another big issue. As we get older, we have bladder issues, pain issues, our sleep is impaired. How do we convert new memory to long-term memory? And the answer is we do it during sleep. We don't sleep well, it doesn't happen. We've all, I suspect from this audience, have done all-nighters to get through school, to get through college, to get through exams. We pass the test the next day, and a week later, we have no idea what we studied. I found some great books that I forgot all about, but I passed the test. We have to be aware of our environment. I always remind people, one of the best things you can do is take a walk in the park, because you've got sight and sound and you've got balance because the paths aren't really good. All of this is stimulating your memory. This is wine country. Good news, bad news. People drink more than they should. And this is great, this is the place where we do it. I live next to a vineyard. Big problem. Other problem we don't think about is hearing. If we don't hear it, it doesn't get in. And we're resistant to getting our hearing checked, getting hearing aids. It's amazing how much smarter we get when we put hearing aids in. Depression interferes with memory because you don't care what's going on. And pain is a problem. Pain overrides your input. No matter what you're doing, the people are telling you in the background, my back hurts, my shoulder hurts, my hip hurts. It interferes with memory. We don't pay attention. Big problem with memory. Vision. Sometimes, if your vision gets, your cataracts are getting in the way, it's harder to read. It's harder to watch TV. It's harder to read the scroll on the bottom of the TV. Big part of our brain activity is based on music and your sense of smell. Two of the most complicated systems we have. We don't hear well. If we don't smell well, we have a problem. What about meds? What about the meds? There are a lot of medicines out there. Some of them clearly big league chemo drugs. Some of them we don't think about. Antihistamines, the Tylenol PM, the little over-the-counter sleep meds interfere with memory. People taking over-the-counter Benadryl over the course of a year lose significant memory. And it's not on the medical record because, you didn't tell your doc how much you bought it. You're buying your sleep meds at Costco. Guess what? It's not on the record and your memory is going down. Be very aware of it. There are medicines called anticholinergics. There's actually a funny story about the seasick patches you put on, the scopolamine patches. They really work. They really do. You're on a cruise and suddenly you're feeling you don't mind the boat's rocking. It's really good. Problem is your memory is sinking faster than you want it to do. It's a bad analogy, actually, sinking. But just be aware. I've had somebody call me up. They were frantic. They suddenly memory is really bad. I remember I said, look behind your ear. And they go, oh, they pull it off a half hour later. They go, oh, my memory's back. I mean, it's that fast. There are significant side effects that people don't talk about. Pain is another interesting issue. Pain interferes with memory. Pain medicine interferes with memory. And how do we get the right balance? And the answer is, it's a very, very careful one-on-one to figure out what's the proper balance between treating pain and having pain interfere with your memory. So yeah, this is what I jumped ahead of myself. But clearly, sleep is a problem. Sleeping pills are also a problem. None of them are good for long-term use. Now, a little background, I do a lot of research on medications. And I'll tell you now that the research is 2 months, 3 months, 6 months, and then it's a free-for-all, which says if you're taking a pill where it says take, one a day as needed, what it doesn't tell you is that we have no idea what happens after a month or after 2 months. And we've taken these drugs for years. But the official safety margin is based on studies that are 2 months, 3 months, 6 months at the most. So we're dealing in unknown territory. And when you do studies on these drugs, you eliminate people who have other medical problems. So if I'm doing a research on a new drug, the people in my study don't have diabetes, they don't have hypertension, they've never had a stroke. And when you're looking at an aging population, this is what's out there. And they're taking drugs that we have no idea what they're doing. So how do we store information? Obviously, we're putting information in. Our computer has a really good hard drive, has a lot of memory circuits. Problem is, as we damage the brain, we lose our ability to crosstalk with our stuff. We have strokes, big strokes, small strokes. We have head injuries. Interestingly enough, what people don't realize is that if you fall And even if you catch yourself, your head bounces back and forth. And that little bit of bounce is going to start to cause damage. So falling is an issue in terms of memory, because you're whipping your brain back and forth. Questions coming up now about COVID. Does COVID affect memory? And that's tricky. The answer is the people who had COVID bad enough to be in a hospital, to be on respirators, have long-term memory problems. The people who kind of got a little bit sick, tested positive, never were disabled, seem to be doing okay. Some of the new neurologic data in looking at the brains of people with COVID is finding little remnants of this virus is actually getting into the brain. It's not a full-blown brain infection. My concern is we had a similar pandemic in 1918 to 1926. It was this big, called Spanish flu following World War I. What happened was 20 years later, people who got over the flu developed Parkinson's. There was a very interesting post-encephalitic Parkinson's. Now, as a neurologist and as a research person, I always worry what's going to happen 10 years following COVID. I don't know yet, but I'm concerned. I taught a class during the COVID lockdown to my grandnephews and nieces, Uncle Allan's brain class. And we used this and we said, this is how your brain works. This is your hearing, your vision. I wish it was that easy. I really do. The kids had a great time. Two of my nieces and nephews are physicians, and the kids were giving them anatomy lessons, which I thought was good. But the reality is, our brain looks like that. It's a whole lot more complicated. And so we have to kind of think about how many different connections, how many little dots are going on. It's in the trillion. Could be more. Nobody's really got a good count yet. This is a very interesting slide. This is a PET scan. PET scans are, excuse me, this is not a PET scan. This is a fMRI, functional MRI. fMRIs are saying what part of your brain lights up when you do certain activities. And this is the brain on music. This says music triggers the emotional part of the brain. It triggers the movement part of the brain. It triggers the memory circuits. It triggers coordination circuits. This is a flat picture. Imagine this in 3 dimensions. So that the ultimate stimulus to your brain, we can do a talk on this later if you want, is music and how it triggers memory, makes you dance, makes you sing, makes you smile. Real important to remember that the brain is never that simple little, hearing. You see a little dot, the orange spot that says hearing. It clearly looks like that. So it's not quite. So what do we have in the brain? The brain is an interesting system. It's a mixture of electrical signals going back and forth, triggered by chemicals. So it's like, some of these batteries, it's a lithium ion battery that makes electricity. Your brain runs on a multitude of chemicals, dopamine, serotonin. These are all terms we've heard a lot of. This acetylcholine, norepinephrine, GABA, glutamate. So we've got a pile of chemicals triggering electrical activity. We need oxygen. If you're low oxygen, brain slows down. No oxygen, the brain dies. Timing for brain death with no oxygen starts at 3 minutes. So people who have a heart suddenly stops. People who are drowning have a very narrow window to get oxygen back in the brain. Glucose, you need glucose. Obviously, if somebody gets an insulin overdose, the glucose drops and the brain dies. And too much glucose, of course, gives you diabetic comas and whatever. We need ketones, we need vitamins, we need minerals. Vitamins, an interesting story. Do we get enough vitamins in our diets? Do we need vitamin pills? I'm going to say no. I'm going to say in this community, vitamin pills are superfluous, expensive. I'd rather you spend your money at the farmer's market. Minerals likewise. How many people need extra calcium, magnesium? The answer is probably not in this community. So I'm going to, in spite of the fact that a couple of vitamin companies sponsored my research for a number of years, I'm going to say you don't need them. Okay. Brain is running 24/7. Your body may go to sleep. Your brain gets more active with sleep. So you're burning calories, you're running all kinds of stuff through your brain 24/7. Do I want to rest my brain? And the answer is you really can't. Just got to acknowledge that it's going full speed ahead. How does it fail? What doesn't happen? Clearly strokes, big issue. Lack of oxygen, infections, trauma. Trauma is getting interesting. We think of major trauma. We don't think about minor trauma. We've finally figured out that football players, playing tackle football is not a safe thing to do. If your kids or grandkids ask, should I play tackle football? And the answer is hell no. Not even close. I have to admit, I'm a small enough person that nobody asked me to play football. But I'm really good at squash. But we started to notice that even other sports have risk on the brain. Soccer players. How do soccer players do? Well, it turned out that we used to think that soccer players heading the ball caused brain injuries. But it turns out it's heading the ball against the other guy's head that caused the injury. It wasn't hitting the ball, it was hitting head to head, which was much harder and coming much faster. So a lot of the junior sports now said you can't head the ball, which makes a whole lot of sense. A lot of the sports people saying, there's no tackle football until a certain age. So if we looked at the age where football caused injuries, it had to do with how young were you when you started. Even among professional football players. Professional football players who started when they were 8 got a lot of brain damage. Professional football players who started at 14 did not. So clearly the developing brain was extremely susceptible to injury that becomes long-term. Toxic chemicals and our brain. What have we got in Sonoma County? We have mercury. We have mercury coming down from Clear Lake. We have mercury coming down from a town called Mercuryville, north of Geyserville. This area used to have mercury mines. Fish in Clear Lake, if you eat more than 2, it's dangerous. Fish in San Francisco Bay is full of mercury. You have to be very careful about mercury in this community. Fortunately, our food chain doesn't have it, but wild caught fish do around here. There's another toxic chemical, I'm going to go a little off record, that says that Roundup and herbicides that are, we thought about them in Vietnam, Agent Orange, we think about it in farmers, but the reality is we're seeing injuries in golfers. We're seeing it in baseball players and football players. And the reason is there are no weeds on golf courses, baseball fields, and football fields. They're sprayed with herbicides. And until we get that down, and we publish this data, and needless to say, I got a nasty letter from the lawyers from Monsanto saying, how could I say that their Roundup maybe toxic to football players? But it is. So how do we define dementia? Dementia is a big one. Everybody is scared silly of it, and they should be. Dementia is a progressive cognitive decline from your previous status. So dementia isn't a traumatic injury that leaves you with memory problems. It is a change from your baseline. And so we all have a certain level of change from our baseline. Ironically, I call it the hard drive is getting full. So we have what's called a delayed response, right? Like I know that guy's name 20 minutes too late. We've all done that. We've all had this, and it's a noun delay. It's not a verb. It's always a noun. So it's sort of intriguing to think about how many nouns are buried in our brains, but there, you can get a noun delay with aging. Okay, and it's just considered normal aging. Don't panic. Okay. Alcohol is an interesting issue. When we were in med school, we had a couple of definitions when we asked people how much they drank. Definition one was whatever they tell you, you double it. Definition two is anybody who drank more than you did was an alcoholic. I did part of my training in Boston, and clearly the baseline numbers were ridiculously high. And when I got here and people said, oh, I drink a bottle of wine a day, I said, oh, Boston, that's considered lunch. So it's tricky, but the reality is alcohol is a cumulative toxin. It does a number of things in injuring brain cells. It does a number of things in interfering with normal sleep. So if you have a drink to help you go to sleep, you don't get normal sleep. You need a normal sleep pattern, not a drug-induced sleep pattern, to consolidate memory. So it's important to keep that in mind, that there is the too much is in fact reality out there. What else about cognitive decline? So we talk about dementia. It's not just words. It's judgment. It's orientation. It's getting lost where you shouldn't have gotten lost. It's making terrible decisions. How many times did you buy the Golden Gate Bridge from somebody? Where I grew up, it was the Brooklyn Bridge, but that's another story. So we have to kind of keep in mind that it's not just a word finding problem. Don't panic on it, but it is out there, and it is multiple levels of things that are going wrong. Normal brain football players and boxers. You know, in medicine, we have there's a formal definition called dementia pugilistica. And we've known for a long time that boxers' brains look like that. They really, really get beat up. And in fact, if we think about the famous boxers that we've known, the Joe Louis, Rocky Marciano, Muhammad Ali, every one of them developed dementia. And they developed it pretty significantly. And so, you know, these were the heroes of the day. And you have to say, getting your head pounded is clearly not good for you. The other interesting thing about that, it turned out it was heavyweight boxers and not the lightweight boxers. They could have as many fights as lightweights, but the sheer force coming at you from a lightweight versus coming at you from a 220-pound Muhammad Ali, the difference in force is a geometric progression. It wasn't twice as much, it was 4 times as much, or 16 times as much based on the weight. So heavyweight boxers all got dementias, lightweight boxers, fewer. Also, the boxers who won the most fights got demented. Well, how'd that happen? And the answer is because they kept fighting. The guys who lost the first 3 fights quit. The guys who won the first 3 fights kept going and going and going until their brains looked like this. So the big topic, hot topic, is Alzheimer's disease. What is it? And what are we doing about it? Described in 1907 by a patient who would look back at it, probably didn't have the real Alzheimer's disease. She was 51 years old and had been sinking for 10 years prior to that. So his description, and he was a pathologist and a neurologist, and he showed amyloid plaque, I'll show you a picture of it later, and tangles. So amyloid plaque is a precipitate in the brain. Think of it like rock candy dropping into some brain tissue. And the tangles are the bits of the filaments of the nerve that come apart. If you imagine the nerve fibers are kind of like a coaxial cable with very, very thin fibers. And as they get damaged, the fibers start to flake off. So if your cable starts fraying at the edges, what happens is it's less and less good at sending material. And so the fibrillary tangles we see in Alzheimer's disease. We also see it in brain injuries of all kinds now, are documenting the unraveling of the nerve itself. And so it's the two things together that make the difference. So amyloid's an interesting chemical. We need it. So it turns out that so amyloid is a normal chemical in the system. It starts as a big, long protein with multiple amino acids, and then you break it into segments. And there's a segment that's 38 units long and 40 units long and 42. And there's usually a balance. But if there's too much of the 42, it precipitates. So the first attempt we did was to stop amyloid in the brain. Turned out that all the blood vessels sprung a leak. You need amyloid at a certain level. You can't take it all out. It's like, if my glucose is too high, can I lower it? There's too much lowering. You can't take the amyloid out. But we try to figure out, could we just take out the amyloid 42? And so far, we're not there yet. So again, if those amyloid plaques you can see up there are, where is it? So the amyloid plaques basically are these little precipitates in the brain. We can see them in people with Alzheimer's disease. We look at brains. The little tangles are literally in and along the nerve itself. So we can see them on pathology slides. We're actually finally able to see them in other ways. Previously, until very recently, we diagnosed Alzheimer's disease on autopsies, which is, a hell of a way to have to go about it. It's a little too late, I think. Now, and when I was a student, that's all we could do. And we diagnosed people with dementia, with Alzheimer's, and we did a lot of autopsies then. And we were right about half the time. Pretty bad average if you think about it. What did people have now looking back at it? And the answer is previously, and I got to say this is improvement. We had people with bad vascular disease that, because we didn't manage hypertension very well, we had people with toxic chemicals in their system. We didn't look at that real well. And we had, half the world smoked. And so over time, as we control blood pressure, we control smoking, we've eliminated 50% of the dementia we used to see. So instead of people getting demented from vascular disease in their 50s and 60s, we've moved that curve 20 years. Alzheimer's, dementia in general, we've moved the curve 10 years just by blood pressure management. So, it's not a bad start. We can do what's called a PET scan. PET scan looks as a radioisotope that attaches to amyloid. So the first one, HC, is a human control. The middle one is Alzheimer's, lights up. The third one is another dementia. It's called frontotemporal dementia. And that has no amyloid at all. So not all dementia is Alzheimer's disease. Vast majority is. But this scanning technique has allowed us to actually separate out amyloid from non-amyloid. We can look at spinal fluid. Nobody wants to do that as a routine test. And it turns out when we do it as a research topic. We've got to find out what's there, what are our treatments doing. So amyloid in spinal fluid is low in Alzheimer's disease because it's all precipitated out in the brain. If you dissolve the amyloid in the brain with some of these newer drugs, the amyloid in the spinal fluid goes up. Tau, the other marker, the fibrillary tangles, is high in spinal fluid when you're doing a diagnostic test. And if you treat people to, improve the nerve function, the tau goes down. So now we have a brand new blood test, just approved last 3 months, that says we can do tau on a blood test, plain old blood test. It tells me how much tau is in the system, which is a surrogate marker for amyloid in the system. So at this point, you can get a blood test. You don't need a spinal fluid, and you don't need a PET scan, which is actually a $5,000 test, not covered by insurance, unfortunately. But a blood test is. So we're closing in on diagnostic markers. There's also a genetic test you probably heard about that gives you the risk factor for Alzheimer's, and it's called ApoE, a lipoprotein enzyme. And it's an enzyme that breaks down lipids. If you're certain variants of it, very high breakdown of lipids, amyloid is a type of lipid. If you have that marker, your risk of Alzheimer's goes down and your risk of heart attacks goes down. They're all lipid related. If you have a different genetic marker that says it's a low active, your risk of Alzheimer's goes up, your risk of heart disease goes up. This is the slide. This gives you the risk. So a genetic marker means you have 2 markers for each gene. So you can have an E2, E3, and an E4. Those are the markers. And then you've got the mix, what's available. The 2s are very, very protective. Fortunately, they're rare. 3 gets you closer to the average. When you get a 4, your risk goes up, and it goes up a lot. So now the problem is you can get a genetic marker, you can get a blood test, and it says your risk of Alzheimer's is really high. The panic, of course, is that, what do I do about it? What can I do about it? There's no treatment, there's no drug out there. So that's going to be an issue. I'll go over some of the prevention strategies, but right now, these are very good at creating a lot of anxiety. They're out there, but I'm not sure I don't want to get one. Let me put it that way. So can we treat dementia in general? To some extent, we can, since we know a lot of the risk factors, medications, sleep, chemicals. We can treat that. We can actually, we know how to do this. We know how to manage high blood pressure. If we do the right stuff, no matter what chemicals are in the brain, the risk of dementia goes down. Hearing, depression, isolation. Isolation was a big problem in COVID. People were isolated. They could not get out and socialize. If you don't socialize, you lose a whole lot of back and forth activity. Think about how much brain activity goes on in a conversation. I hear it, I interpret it, I figure out what it means, and I answer it in a millisecond. How many brain functions are going on holding a conversation? They don't happen watching a computer. They don't happen watching TV. They happen in conversations. So being isolated, not being with people with this really fast was very bad for people's brain health. What are we doing research-wise? What are we up to? We tried vaccines. That hasn't done anything. We have antibodies, and we'll get to that. Some of them are getting there. Production of amyloid, can we change the amyloid precursor protein? Can we change how it breaks down into, instead of making amyloid 42, can we just make amyloid 40? can we change the enzyme? We did that. Came up with a great drug. It looked wonderful. Cured it. Rats, we could cure rats. Alzheimer's, really did. We gave this drug to humans and they got liver toxicity and didn't work. But we're working on it. Estrogen was an interesting because women have a higher incidence of Alzheimer's than men. And it invariably kicks in as their estrogen levels drop. So the question was, if we used estrogen-like drugs to prevent dementia in people at high risk, would it work? And the answer is it didn't work. And the estrogen and estrogen-like drugs had more of a risk of heart disease and cancer. So clearly risk was much higher than benefit. Everyone thinks that vitamins will cure their dementia. Nope, not going to happen. Nicotine is a very interesting drug. Nicotine is preventive, only in retrospect. So people who used to smoke had less dementia and they had less Parkinson's disease. So clearly something in nicotine triggered the brain. They could have smoked for 5 years when they were 20 to 25 or 15 to 20 and never smoked again. That gave a long-term effect on the brain that lowered the risk of Alzheimer's disease and Parkinson's. So now the question is, what if I use a nicotine patch? Might that work? And the answer, I don't know, but it's an interesting concept. Think of nicotine, pure nicotine, not smoke, not any of the other garbage, helping your brain. Anti-inflammatories, ibuprofen, good old Motrin. For some people, changes inflammatory response in the brain, and it may slow the development of dementia, may slow Alzheimer's disease. How much, how long can you take it? Again, we're looking retrospective reviews. We don't do it, we're not going forward with it. So, how do we identify a group that we can treat and see, does this make a difference? The problem is all of these are going to take 5 years, 10 years, 20 years to see the effect. There's no research study that's going to go for 20 years. No one's going to, hard to do, and no one's going to pay for it. The other problem. Cannabis. There are those who believe cannabis cures the world. I'm not sure. So far, nobody's proved it. And problem with smoking it, vaping it, there's certainly some use in the pure chemical THC and CBDs, and they do have anti-inflammatory effect, but the drug law puts that in the same category as heroin, so it's really hard to use it for research. What are the new drugs? What are the old drugs? Well, what's in the papers these days? Aricept, old drug, donepezil, been around 25 years. It changed the amount of acetylcholine in the brain. We know when we study these brains, acetylcholine is low. If we can increase the amount of acetylcholine, did it improve function? And the answer is it did. It didn't change the course of the illness, but it gave you a window. So people got better for a year or 2 or 3 on it. And as they got worse, we said, well, it's not working. We took it away, and we took it away, they got much worse. So clearly it was doing something. And it's still used. It's still a first-line drug. We added some new monoclonal antibodies. These are the ones you've heard about. They're in the papers, the lecanemab, donanemab, and aducanumab, Aduhelm, which, by the way, got dropped finally. These are 3 drugs. They're monoclonal antibodies. They're given IV to people who have early dementia, early Alzheimer's, because to do this, you had to do PET scans or spinal fluid to know exactly that they had Alzheimer's and not frontotemporal dementia or not something else. So we use these drugs. Now, in a quick disclosure, I was the principal investigator on all of these drugs. So I have some inside scoop, and what I tell you, maybe breaking confidentiality agreements, but I'm not going to worry about it at this point. But what the monoclonals did was they dissolved amyloid plaque. And we could do PET scans and say there's less amyloid. They prevented plaque from forming. Seemed to work also. But if they took out too much amyloid, the blood vessels started to leak. So the side effect of these drugs is you got swelling in the brain, you got bleeding in the brain to figure out what's the right dose, what's the right amount. It's a tricky equation. So the drugs that got approved, the first one was aducanumab, Aduhelm, over great controversy. The FDA's advisory committee said, don't do it. The FDA approved it, which was a very political decision. Clearly, AARP and the Alzheimer's Association put huge pressure to get some drug, any drug, after billions of dollars being spent, give me something, give me a hint. So they approved a drug that was really not very good. And fortunately, nobody prescribed it. And in spite of the proposed multi-billion-dollar revenue they were going to get, they got, I think, $110,000 in revenue in the first 2 years, and they dropped it. The newer drugs, lecanemab has been approved. Leqembi, you probably heard about it, read about it. It's an IV drug every 2 weeks, which is one hell of a way to be tied to a IV pole. You know, it's weird to go on vacation if you got to be on a drug every 2 weeks, IV. And again, it had some risk of swelling, some risk of, bleeding. Donanemab similarly has some risk of swelling. Now, that said, the dilemma is that we started the studies on people who had mild cognitive impairment, which meant they were already going down. They had amyloid in the brain, they had tau in the brain, they had a disease that had crossed a threshold and was now on a downhill course. And the problem with a downhill course, if you slow it slightly, and that's all they did, if you slow it slightly, how good is that? What we really want in our medical care is to prevent disease, to stop disease. Slowing it by 2 months doesn't make a whole lot of sense. And that's where they are right now. There are some newer studies, and I'm an investigator on one of them. We're taking people who are normal, but have a positive blood test for amyloid, a positive blood test for tau, positive PET scan, but they're normal. And we're trying to use, in this case, donanemab, to see if we prevent decline. Because once it starts, it's a runaway train. It's not going to stop no matter what. So this is where we're looking now, is saying, can I identify high risk? I mean, the argument I use is, if you've got a high cholesterol and you're 40 years old, I'm not going to wait until you're 60 and have a stroke or a heart attack. I'm going to treat your high cholesterol as a prevention. And it's worked, because the reality is, we used to, when I was a student, Tom, maybe the same bit, we had a whole ICU of 50-year-olds with heart attacks. And now we don't do that, because now we've treated blood pressure, we've treated lipids preventively, and we've moved the curve. We've moved quality of life years by 25 years. We get heart attacks, still get them, but we don't get them at 50 anymore. We get them at 75, 80. So prevention strategies, what are the risks? Now, so we know that amyloid, a genetic marker, tau, says you're in a high-risk group. That's who we should be treating with these drugs to reduce amyloid. There's a study currently going on now. I'm here in Sonoma County. I'm the investigator on donanemab, taking people who are normal. And we're giving them the drug for 9 doses only, because we found out that after 9 doses, we've taken out 90% of the amyloid. And so you don't need to be on this drug forever. If it works, it'll be great. I'm really hopeful that this drug works, but I'm even more hopeful that we're looking now at prevention strategies and we're not trying to treat a disease that's really out of control. This is a model that we've used for years to figure out when and how to treat people. Now, first line, the orange line is amyloid. Amyloid goes up during a long stretch of being perfectly normal. Tau goes up also when you're still really normal. Next line. Third line says the brain starts to shrink. And then your memory starts to go. But if you take that first dotted line and move it backward, what you see is that there's a huge cognitively normal stretch when you've got positive biomarkers where we should be treating. But in fact, we're treating between the two dotted lines with the MCI, a mild cognitive impairment, because it's a narrow window and it's cheaper to do a study. On a narrow window, it's very expensive to do a study on a big wide window. And that's where we're stuck right now. But I think there's potential to start looking at more and more people with positive markers as the drugs are getting safer and easier to use. And then you don't need to be on them every 2 weeks. You may be on them for 6 doses or 8 doses and quit. Okay. Blood flow and dementia. Anything that interferes with blood flow causes dementia. Can we increase blood flow in small vessels? New data came out just a couple of weeks ago that said people who use Viagra have less dementia. Interesting, right? Increases blood flow in small vessels. Well, wait a minute, we got that drug. So they're going to look now at now the beauty of that, this drug's been around for 20 years. It's been used in older people. It's been used safely. I mean, God, what could be a better potential treatment? So anyway, so we're looking at that. I'm not sure how they're looking, but right now it's background material. But it could be a lot of fun. So we do know from a large study out of Chicago that people lifestyle made a difference. They studied a large group of elderly people. They looked at their lifestyle. And then when they died, they had their brains autopsied. A whole lot of them had positive amyloid, tau, looked like a perfect Alzheimer's brain. These people had no cognitive deficit. What did they do differently? They managed their blood pressure. They managed diabetes. They were socially active. They were involved in educational programs. They took classes. They taught classes. They ate really good diets. They avoided smog, smoke. Hard to do all of it, but even parts of it. They took care of their teeth. Turns out that gum disease is a big risk factor for dementia. The bugs that get into your gums get into your brain. So be aware. So they found that that worked also. But you could find people who have all the pathology of Alzheimer's, but no dementia. And it was behavior that made a difference. Okay. Your microphones.
Okay, I wonder if we have any questions at all. So Lynn and I will be passing out the microphones. So please wait till we get to you. Then you can turn lights on. Thank you.
Yeah, I'm going to start by asking,
They got the mics.
do you need any more subjects for your research study on donanemab?
Currently, no. Currently, my study is full, but I'm looking to get new ones, and in which case I will let everybody know.
Am I on? I'm on, okay.
You're on.
When the person introduced you initially, they said something about you either worked with or studied migraines. I wondered if you had any studies or know of anybody who studied acute confusional migraine.
I used to. I'm not currently. Yeah, acute confusional migraine is a tough topic, but I used to study it.
So
but
are there
not
any,
currently, no.
I'm just asking, are there any, is there written material about it or other
Yeah,
individuals
go
studying?
to the American Headache Society website and they have really good tutorials on all the different variations of migraine. But the American Headache Society has the, yeah,
I wonder if you would speak for just a moment on the effect that migraines have on the brain, if you've had them for years and years.
good question. And migraine does not interfere with the brain. Migraine may be protective. And the reason it's protective is because people with migraine limit alcohol or don't drink at all. They limit exposure to toxic chemicals because it triggers migraine. So they develop a healthier lifestyle. And so although it may be upsetting when you're younger and have active migraine, the long-term effect of behavior modification in migraine people makes them age better.
Okay, thank you
Okay.
so much for your talk. It was super interesting. I have a question about, you've studied physical trauma, but what about emotional and psychological trauma? Does that affect memory over time? And the other question is about sleep aids. What about trazodone, which is not an anticholinergic and not a benzo? Have you got any knowledge of the long-term effects of using trazodone for sleep?
Okay, take two questions. Answer number one on emotional psychological trauma is it does cause brain damage. There's no question. The PTSD phenomena interferes with the ability to focus and your ability to pay attention to real, what I'll call the real world, because your brain is churning old material. So emotional stress is a factor. Second question, trazodone has never been approved as a sleep medicine, and it gives you what I call a drug-induced sleep, not a normal sleep pattern with, stage 1, 2, 3 REM. It's an artificial sleep pattern. So it's probably better if you can not use it.
On the issue of Roundup, how is it absorbed and is there anything you can do to mitigate it?
It's absorbed mostly through skin contact and through, breathing it. Like I said, football players who skid on the grass, but even in golfers, it turns out, because it's in the air, they spray it, the sun comes up, it evaporates up off the grass. So it is a potential toxin that comes in. There's very little in the food supply these days, but you do get direct contact.
So Alzheimer's and dementia are two progressive diseases.
Dementia is a broad category. Alzheimer's is a specific form of dementia.
Okay,
There are other forms of dementia.
so aphasia and memory loss, are they possibly to be reversed sometime in the future?
Have not figured out how to reverse it. Okay, I mean, the focus is we can't undo brain damage at this point. The big focus we have is trying to prevent it. Prevent, on that last slide where I had, stuff's going wrong, but cognition is normal. And I keep everything on that side of the slide going to maintain normal cognition. There's some work now on aphasia from strokes using electrodes to stimulate the brain to make new cells. The brain doesn't make much in the way of new cells, but we're working on a project with stroke patients to putting a stimulating electrode in to draw cells into an area of damage. See if I can rebuild part of the brain. We've done it in animals, and I'm part of a research group out of UC Davis working on that as well. But so far in humans, the answer is we're not there yet.
Good morning. Thank you so much for making a very complicated topic simple for everybody to understand. I'm sure we'll all be in agreement there on that. My question is I served my internship over at California Pacific Medical Center. And it's only an honorary doctorate, so don't get too excited. But something that MIT is on the vanguard about is the use of Hertz frequencies. They've got 6 years of longitudinal studies. It specifically breaks down the amyloid and tau plaques, and it's done with sound and light. Sound and light. And you can literally, if you have an iPad, you can download the program for, I don't know how much it is, but I don't think it's very expensive. But basically, I had seen it on a TED Talk. It was done by one doctor, and then another doctor did the same research, and then another and another. Now we're looking at almost 10 years into this research. And by just having a light stimulation at a certain gamma hertz frequency, 40, and a 40 hertz auditory stimulation, the frontal lobe and the parietal lobes are regenerating, and it's amazing. Can you speak to that research?
I don't know it in great detail. I mean, I've read about it and it's certainly fascinating to think about a non-invasive, non-drug way to modify brain's function. I think it's a great thing. The material, the equipment needed to do it is extremely complicated when I was reading it. And the problem was trying to expand it into a wider field. I'd love to see it spread more because it meets all the criteria. Yep. Yep.
You've
I
answered your question.
I agree. Okay, go ahead.
Right here. Is Prevagen snake oil?
Yes, Prevagen is snake oil. That's a quick answer.
Well, you have projections on two parts, male versus female projection on getting dementias, and then age groups, 70s, 80s, 90s. What are the percentages?
The percentages run up into 50% when you get to 90s. 50% of 90-year-olds have some kind of dementia. And it's a little bit higher in women than in men, from the onset to lifelong on it. But it starts at, 20%, 30, and hits 50 as you get above 90.
Okay, a question about PTSD.
Yep.
Yeah, what are the differences physiologically between traumatic memories and normal memories?
Traumatic memories are associated typically with some kind of physical, change in the brain. In other words, the brain with traumatic events, and they don't have to be physical trauma, will increase their cortisol levels. In other words, you get a slightly elevated steroid level running through the system on a lifelong basis, which causes all kinds of physiologic changes in the system, including, cataracts, thinning bones, psychological depression. All of those are related to increased steroids. We know if you give somebody steroids for a long time for the skin rash, whatever, bad things happen. PTSD does it on a micro level, but it does it for multitude of years. It's a cumulative effect of a steroid overdose.
Could you give us quickly your thoughts on Neuralink?
Don't know it.
That's Elon Musk's implant.
I'm going to wait a long time for implants, brain implants. Have a long way to go.
Would you speak to the interaction or how they're connected of fibromyalgia and the brain?
Hard to say. Fibromyalgia is related to probably a long-term antibody phenomena that it's an autoimmune phenomena are probably related to a remote herpetic-like infection. And it's inflammatory. So all these inflammatory markers get in the brain. I mean, that's how dental disease gets in the brain. That's how, so inflammatory markers do end up in the brain. We're looking at the post-COVID, for example. So it's got some long-term, concerns.
How about marijuana for sleep? What is your opinion about that?
Any drug for sleep is probably not a great idea. I mean, marijuana may have a lot of potential use. I mean, neurologist, I study epilepsy. There's all kinds of good data on THC in treating epilepsy. But I'm not sure for sleep, any chemical intervention is going to be the ultimate answer.
Yeah, I have a question about Parkinson's and Lewy body leading to Alzheimer's. Is there a connection there?
Parkinson's is associated with Lewy body. Lewy body is Lewy, of course, is another pathologist beside Dr. Alzheimer. Lewy bodies are deposits in the brain that are associated with the significant dementia, and they're common with Parkinson's. And, it's not an amyloid at all. So if you look at those PET scans, you can see Lewy body dementia doesn't have amyloid, but it's a very progressive dementia. And because it's harder to diagnose, there's very little research going on in that field.
Yes, I heard on the radio that this man wanted to reduce his cholesterol, and they got it so low that he died from it. I'm not
True.
Yeah.
Yeah, you do need a certain amount of lipids for the brain to work. There was a very interesting study. I'm going to float back for about 25 years ago, somebody in Scandinavia, where they have a very high lipid diet, a lot of butter and cheese and meat, and they had a lot of heart attacks and strokes. And they said, well, if we could get a group of people on an extremely low fat, no fat in their diet at all, compared to the normal, what would happen? And they ran this study for about 2 years. And over the course of 2 years, the death rate was the same. The people on high fat diets had heart attacks and strokes, and the people on low fat diets had suicide and traumatic events. They did not do well on no fat in their diet. Remember, Shakespeare talked about the jolly fat man and the mean and lean guys. Okay, it works. He was a good observer.
What is the pathophysiology of microvascular dementia?
Microvascular dementia. Microvascular dementia is related to hypertension. And if we treat hypertension really well, we don't get it. So vascular disease happens with diabetes, but mostly it happens with smoking, but it also happens just plain old high blood pressure, damages small vessels, and it damages them cumulatively over the years. And pretty soon you've got gaps in the oxygen flow into the brain from microvascular. Now, I'm going to diverge for a minute again because methamphetamine, hopefully not a big issue here, but methamphetamine in the community, methamphetamine damages blood vessels, and it damages them permanently. So people who used to use meth in their 20s get strokes in their 40s. And they go, wait a minute, I'm clean, I'm sober, my blood pressure is good. And the answer is permanent damage to blood vessels.
I'm assuming that the studies that you're referring to are mostly done in US. Is that so?
They're done worldwide.
Oh, good. Because having been an acupuncturist for years, what I want to say is that Chinese medicine has a really impacting approach to the brain, and it actually has a meridian that connects to the brain. And I just think it would be wonderful to get an integration of all of these studies and see what, I don't know what the studies are on, Alzheimer's in China, in places that are practicing that as a medicine. But it would be really, really great to get an integration of these studies together and find out what we might be able to get together if what we have, if we could get together with all of this, you know.
I agree completely. I mean, we really need to integrate all of traditional medicine practices, herbal medicine, acupuncture, yoga. I mean, all of these biofeedback. There's a massive amount of medical care that does not involve adding a chemical to the system. I agree with you 100%. And I'd love to see that integrated in. And we know people's behavior, activity, diets changes their risk of dementia. Even if they have changes in their brain, they don't get demented. Acupuncture is a great drug.
In 2008, would doctors have been able to, when they took a look at the brain, been able to determine whether the damage that was caused by the accident the person was in, would they have been able to determine possibly the onset of dementia or some form of it?
Probably not. You know, the problem with dementia is that it's a wide spectrum that doesn't appear right away. A single traumatic event may give you damage, but dementia by definition is a progressive disease. Okay, so you can get a brain injury, but dementia is a cumulative effect of things getting worse over years and years. So it's different. So boxers with terrible looking brains have dementia, but not Alzheimer's disease, for example, from just multifocal areas of damage.
Could you discuss long-term versus short-term memory loss?
Short-term is real common, okay? We all don't register stuff. Long-term is trickier. Think about your memory circuits like a great big onion. You've got layers and layers and layers and layers, and the newest materials on the outside. And over time with aging, the outside peels a little bit, peels away, things don't stick. So we lose more recent stuff more easily. The stuff in the middle, you know, the language you spoke as a kid, your manners, how to eat, you know, toilet training is way in the middle of the onion. Doesn't, you know, no matter how much you're losing your ability to make new memories, the old stuff is still there. You know, you ask men who've been in the military 60 years ago about their military, they tell you all about it. Ask them what they did last week, they don't remember. So it's the middle of the onion, but it's that outer onion getting papery. Things just don't stick as well as we get older. I can tell you about it.
So we're supposed to reduce alcohol. How about all the people, my whole family, all my friends who just love wine? They drink a whole bottle every night between two of them. How much is wine just more diluted so it's not as bad?
No, it's a total alcohol intake. The original research we did, and I'll have to admit I was one of the authors on this one, talked about what's called the J curve, which says that with one drink, your risk of heart attacks and strokes goes down. With two drinks, you're back to even. And with three or more, your risk starts to climb. So when you get above two drinks, your risk of all kinds of damage to the system goes up. Now, wine is a little bit easier because people tend to do it with food, and you don't end up to the people who drink a lot of just whiskey or beer and don't eat, have problems. And the problem there, a lot of it is nutritional. They get vitamin deficiencies of all sorts. So wine drinkers generally eat better, but a bottle of wine is too much alcohol, no matter what.
What about melatonin for sleep?
Melatonin for sleep, it's relatively safe. It hasn't had a big problem. But again, long term, we're not sure. Okay, probably the safest of the things out there. And it's dose related. If you have a dose of 2 milligrams or 4 milligrams, that's fine. When you get to 8 or 10, you start getting nightmares and hallucinations. So there are doses. It's over the counter, and people don't warn you how much is too much, but there is too much.
You spoke a bit about acetylcholinesterase.
Yep.
I'm wondering, I know that you're anti-vitamin, but what about amino acid therapy?
Not necessary if your diet's good.
I'm wondering about frontal temporal dementia. Can you talk a little bit about that?
Yeah, it's not much to talk about because there's not much research on it. It is a non-amyloid, non-tau breakdown in the frontal lobe, so it affects predominantly judgment. People with frontotemporal dementia sound good and they sound smart and they have all the right answers, and then they do something totally absurd, like, emptying their bank account to buy the bridge. Stuff like that. It's a behavioral abnormality primarily in the judgment, areas of judgment. They make terrible, and then eventually they get a more generalized kind of dementia. But there's not much research. It's because it's hard to diagnose. In other words, amyloid I can picture. Lewy body I can't picture. Frontotemporal I can't picture. So we're looking at it retroactively when we see the brains.
I only take a couple of prescriptions, but I have a lot of other pills that have been suggested referred to me. And you're making me think that those are, like vitamins and stuff, that I should drop that stuff. I don't like taking all those pills anyway.
Well, you need your blood pressure meds. And if your lipids are high, you need those treated. And if you've ever had, heart problems, you probably need an aspirin a day. And after that, I'd stop. But, most of the vitamins and minerals in this community, and again, this is a very specific community. You have access to good, healthy food. You don't need vitamins and minerals.
And our last question right here.
I was interested in the relation between ADD and ADHD because they have some of the PTSD type and frontal temple. There's a lot of symptoms.
Yeah, ADHD and ADD, again, these hyperactive, there's an interesting phenomena there. Part of that with the PTSD is a failure to forget properly. Because we normally remember stuff and we forget. We have to keep forgetting. Forgetting is very healthy because it prunes in to the important stuff. And if you don't forget properly, the same circuit goes around and around and around and interferes with picking up new material. So that's where PTSD becomes a problem, and the ADHD is similar. They really have a problem in adding new material and pruning out old material. I mean, I drove here today, I stopped behind a truck, I was reading his license plate, and I got this interesting plate. When I got here, what's the plate? I don't remember, and that's good. I could prune out unnecessary material. And if you can't prune it out and it goes around and around, it's a problem. One of my interesting research projects was actually with vitamins. I did a lot of work with pyridoxine, with vitamin B6. And it turned out some of the kids with ADHD, if you got them on pyridoxine, vitamin B6, they got better. And it turned out their diet was the factor because all of the artificial chemicals, the colorings, the flavorings were made from chemicals that blocked their ability to metabolize vitamin B6. So you could change their diets, and if you added B6, they got better. The parents figured it out when they had to give them a pill that was coated purple. They'd wash the pill and get the color off it, and then the kid was okay. But if they didn't wash the pill, the kid got hyperactive when they took their medicine. So, Tom, you probably know that all the pediatric medicine is grape flavored or cherry flavored, and it's colored. And it's bad for them. Parents knew it better than we did.
Alan, we want to thank you for a fantastic presentation today. Thank you so much. Thank you. You're welcome back anytime. I want to